aortic aneurysm. Aortic aneurysms are mostly abdominal, and 90% are below the renal arteries. They are permanent and a localized dilation of abdominal aorta to at least 50% in comparison to the normal diameter of the aorta. Usually discovered incidentally during physical examination or radiological investigation. They are usually asymptomatic, and physical examination wise, the sensitivity is higher for aortic abdominal aneurysm greater than 5 centimeters in size. What we would see is a patient with pulsatile abdominal mass with abdominal bruit. The mass could be tender. The patient would have early satiety, nausea, vomiting due to compression of adjacent bowel. The patient could complain of abdominal pain radiating to flank or the groin area. Now, in case if there's a thrombus sitting in the aneurysm, there could be a distal embolization with pain in the feet and some kind of discoloration. The ureteral obstruction and hydronephrosis could be there, leading to flank and groin pain. And the rupture would present as hypoperfusion, abdominal pain, shock, and there could be fistulas occasionally. If there's an aortocaval fistula, there would be a loud abdominal bruit. In case of an aortic fistula, there could be hematemesis, melena, with abdominal or back pain. And then iliocaval venous compression could be there, which could lead to venous thrombosis. Etiology-wise, the most important would be atherosclerosis and smoking tobacco, hypertension, high cholesterol, vascular diseases, Ehlers-Danlos syndrome, Marfan syndrome, with arthritis, especially inflammatory arthritis, then syphilis, mycotic. But the most important would, of course, be atherosclerosis. Diagnosis-wise, imaging would be the most important thing. Abdominal ultrasound is almost 100% accurate in identifying aneurysm, and size estimation within 0.3 to 0.4 centimeters. CT is utilized in preoperative aneurysm imaging, and especially to determine this extension proximally to arteries, and to determine the integrity and finding out any rupture issues. So CT is better at it, and CT is utilized in that scenario. Of course, the CT estimates size 2.3 mm, and angiography is useful preoperatively to assess the location of the aneurysm in relation to other arteries. Treatment-wise, the aneurysm rupture is an emergency with surgery an absolute essential for survival. And the predictor of rupture would be the maximum diameter of the aneurysm. So if there's an abdominal aortic aneurysm which is greater than 5.5 centimeters or larger, surgery is recommended, and the mortality post-rupture would be greater than 90% because most are not able to reach the hospital on time. In case a patient can make it to the hospital on time, the mortality would come down to 50%. And for an elective repair of a non-ruptured aorta, the mortality is way down 4%. So basically, time is key. If the person can reach the hospital on time post-rupture, the mortality would obviously be less, and for elective repair before rupture, the mortality would be way down. So time is key. Monitoring is very essential for aneurysms less than 5 centimeters in diameter, and basically an ultrasonography can be utilized and see the progression of the aneurysm during different intervals of time. And as the size goes above 5.5 centimeters, in case of an abdominal aneurysm, surgery is recommended, and greater than 6 centimeters in thoracic, surgery is there. Or if it's even if it's a smaller aneurysm but it's rapidly enlarging, then also surgery is recommended. DD-wise, you might want to consider abdominal pain or back pain, and there are a few techniques for an endovascular aortic aneurysm repair, and they would be an aortic stent graft, or an aortic uni-iliac device with femoral crossover graft, or a bifurcation graft, or a three-part modular device. So basically, the key thing here in aortic aneurysm etiology-wise would be atherosclerosis, and time is key. Basically, if the size is greater than 5.5 centimeters, surgery is recommended, and basically an ultrasonography would be an investigation to determine the progression of the aneurysm in different time intervals to see how it's progressing. But a too rapidly progressing or enlarging aneurysm would also be an indication for surgery.